Director of the Dominantly Inherited Alzheimer's Network Trials Unit, and today we're going to be presenting results on delaying symptom onset and dominantly inherited Alzheimer's disease, long-term Gantenerumab treatment results from the DIAN-2 trial. Okay. And I guess, oh, there we go. Welcome to Philadelphia. And my slides should be coming up. There we go. Okay, so I'm going to review the clinical and the amyloid tau and neurodegeneration findings. I'm going to be reviewing the clinical cognitive effects that were seen in the open label extension part of the DIAN-2 trial. And I'm going to be describing the background of what the trial, how the trial was designed, implemented, and what the top line findings are. Our sources of research support are shown here, as well as my disclosures. The DIAN-2 trial platform started in 2012. At that time, we launched one of the first prevention trials in Alzheimer's disease in a design where we had two different drugs, solanezumab and gantenerumab, randomized in a double-blind fashion, which ended in 2019. After a gap period off of drug, we resumed with an open label extension of gantenerumab, which concluded this past year. It's those results that we'll be presenting in the top part today. The trial design was a phase 2/3 placebo-controlled, double-blinded, biomarker-based trial that transitioned to a cognitive outcome trial. You can see that we enrolled 194 people, of whom 52 were assigned to gantenerumab, 52 to solanezumab, 40 to placebo, and the non-carriers were automatically assigned to placebo. We had a range of disease stages and states in the trial. Some people, when they came in, were asymptomatic, and their estimated years to symptom onset was negative up to -15, while other people were symptomatic with a clinical dementia rating of 0.5 or 1. Of the 194 enrolled to reach 144 mutation carriers, the drug treatment duration was up to a maximum of 7 years, a 4-year minimum, and an average of 5.2 years. Partway through the study, we increased the dose of gantenerumab, where we increased it 5-fold at 2 years, and solanezumab was increased 4-fold in the last year of the study. Enrollment completed in 2015, and our top-line results from that period were released in 2020. I mentioned that the Gantt OLE continued from 2020 until this year, 2024, with a 3-year planned last patient in trial design. At the time that this period went, I'll review the Gantt dosing here. The 144 carriers reached a target dose of 1,200 milligrams every 4 weeks in the double-blind part of the study, and of those that entered, 105 completed the double-blind period. Of those 105 people who completed, 74 entered this open label extension period, and we tripled the dose again to reach a goal of 1,500 milligrams every 2 weeks. The primary objective for this final analysis was to determine if continued treatment with gantenerumab at its target dose could result in a continued or complete removal of brain amyloid plaques as measured by PIB-PET. There were key secondary objectives for the final analysis, including pre-specified outcomes on the clinical dementia rating sum of boxes and the global scale, tau PET SUVR, and cerebrospinal fluid biomarkers. We also did an interim analysis partway through the open label extension to look at these measures, where the primary analysis was the clinical dementia rating sum of boxes and global and a Cox proportional hazard ratio. In the final analysis, our primary outcome was positive, with substantial reduction in amyloid plaques as measured by PIB-PET, demonstrating the removal of amyloid by substantial amounts and approximately 3-fold higher than what we had seen in the double-blind period with the increase in dose. You can see here the SUVR decreased to 0.71, lower than baseline at OLE, and that represented approximately a 29 centiloid drop from their entry into the study. As part of our pre-specified analysis, we sought to determine what effects there were in the clinical progression of these individuals, And so there were three groups that I'll describe. One, which we call the any Gantenerumab treated group, was anyone who had ever received Gantenerumab from the beginning of the double-blind period or the open-label extension, and we compared that group to both the Diane observational study that was progressing at the same time, combined with the placebo group that had never been exposed to drug. Its Cox proportional hazard ratio was not significantly different from 1, indicating there was overall no clinical effect in the progression of the CDR global or sum of boxes. The other pre-specified group was the longest Gantenerumab treated group. These individuals started on Gantenerumab at the beginning of the trial and continued on dosing throughout the double-blind period. They had a gap period of approximately 1 year and then resumed treatment in the open-label extension period. We compared that group to the same placebo group and also to the extended controls shown in purple. This allowed us to better match the longitudinal follow-up time between the control group and the group that was treated. You can see that this group had approximately a 50% lowering of the clinical dementia rating global and sum of box progression rates from the asymptomatic state that they started in to symptomatic compared to controls. And finally, the last group was the group that was only treated during the open label extension period with the highest doses compared to a control group. And again, you see no significant difference in the progression of CDR global or sum of boxes. These findings indicate to us that it may be that in order to have a substantial prevention effect, we need to remove amyloid early in the stage of the disease and for long periods of time to substantially reduce the progression. We also think this may be some of the first evidence of clinical prevention in Alzheimer's disease. Shown here is the data that on the progression curves from the same Cox proportional hazards model of progression. And you can see in the top left, the Gantt curve is in blue, the control group is in gray. There's not a significant difference between those curves, and the longest Gantt group in the top right, as well as the longest Gantt group compared to the extended controls in the bottom left, there are nominally significant differences in the progression of the clinical dementia rating. The OLE only Gantt in the bottom right shows no difference. So what could this mean? If there's approximately a 50% reduction in the progression of clinical dementia rating in asymptomatic individuals in this population, we've shown the cognitive composite score modeled by the black line. This is the normal progression in this population so that as people reach 0, there's a slow cognitive decline until they reach the estimated age of symptom onset, and then there's an acceleration, a more rapid decline in their cognition for these two phases. We've modeled what a 50% reduction in clinical progression might mean in terms of years of symptom-free disease, and the green curve shows a proportional reduction in disease progression, and that estimate is people would approximately have about 5 years symptom-free dementia, and the yellow or gold line shows a 50% delay if there's a threshold to symptom onset, so that if you delay the onset of symptom onset, you may be delaying the acceleration of cognitive decline. In that scenario, it's estimated to be approximately 15 years of disease-free time. Shown here are our conclusions and a QR code for a preprint that has been submitted for peer review. This preprint has extensive information on these analyses and the protocol, and you're welcome to take a photo of that and take a look at the preprint. In asymptomatic autosomal dominant Alzheimer's disease, removing plaques for an average of up to 8 years before symptom onset may provide a 50% decrease in the risk of conversion to symptomatic dementia and dementia progression rate. The DIAN-2 trial of Gantenerumab may provide the first proof of principle that removing amyloid plaques may prevent the onset of Alzheimer's disease dementia. There are major caveats in this trial that include the use of external controls in the open label extension period, small numbers of participants, and a limited duration of follow-up past the expected age of onset. Some of these individuals are 3, 5, and 7 years, 10 years past their expected age of symptom onset, but many of them are very close to 0. And so the follow-on studies in this unique cohort will be uniquely informative for us to clearly demonstrate what effect size is seen and what kind of magnitude of benefit might this provide. So we have ongoing studies in this cohort to provide evidence for this, and it's launched, and it's called the Amyloid Removal Trial. It's enrolling former Gantenerumab open-label extension participants, treating with lecanemab open-label for 5 years. And the goal here is to assess the long-term efficacy, up to 15 years total, of being treated with anti-amyloid plaque-removing drugs and the safety of removing amyloid plaques. In these mutation carriers, the amyloid removal trial will seek to determine the clinical effects of these anti-amyloid antibodies, the long-term effects on the rate and the full removal of amyloid plaques, effects of these plaques on longitudinal measures of novel biomarkers, and for side effects such as ARIA. The added value of ART is that it can predict and inform ongoing and future prevention trials, several of which are running in sporadic late-onset Alzheimer's disease. And so the information that we gain in learning from this uniquely informative population of a group of people who have been treated perhaps the longest in the world with amyloid-removing drugs, it will be important for us to learn from to help design our prevention trials, interpret them, and also develop statistical analyses. I mentioned that the trial has been launched just this past month. The first participants are enrolled, and we plan to be fully enrolled in 2025. Shown in this table is a comparison of the DIAN-2 trials and other trials in autosomal dominant Alzheimer's disease compared to sporadic Alzheimer's disease. And you can see in the rightmost column, shown in green, are scenarios where the outcomes of mutation carriers have matched that of late-onset Alzheimer's disease. Shown in yellow are the outstanding trials for which we still have results pending, and so we don't know. But in nearly every case that we've compared, the findings of trials in autosomal dominant Alzheimer's disease have predicted what we've seen in late-onset Alzheimer's disease. There's good reason to believe that by reversing the pathology in this population and getting the pathology to near normal levels, that we can give these people many years, even decades, of disease-free life. And so one historical medical precedent is people with familial hypercholesterolemia that have deposition of cholesterol and atherosclerosis, that if they're treated early enough in life and the pathology is treated, it can be reversed. And by reversing it, these individuals have decades of disease-free life without strokes or heart attacks. And so with that, I want to acknowledge the many people in the many groups over the many years now, more than 10 years, that have contributed to these trials. Importantly, the family members and participants who have had remarkable commitment to enable this kind of long prevention trial to occur and to inform the field. Our many partners include the Alzheimer's Association, philanthropic foundations, our pharmaceutical partners, the National Institute of Aging and National Institutes of Health, and other groups. And finally, the Knight family DIAN-2 sites are shown here that are participating in these trials and additional trials that are ongoing. Okay. Thank you. We're going to hold questions until the discussion panel at the end. So if you have questions, please keep them in mind or write them down. And at the discussion panel, we'll pick up the questions. And with that, Greg, would you introduce the next speaker?
Hello, everyone. My name is Greg Klein from Roche, and it's a pleasure to be a co-chair to this very exciting session from the DIAN-2 results with Randy. Our next speaker is Jorge Libreguera, Associate Professor. He will give a talk titled Safety of Higher Doses of Gantenerumab in the Open Label Extensions of the DIAN-TU-001 trial.
Right. Good morning, and thank you for joining us today, both the ones that are here and also the ones that are joined virtual. Today I'm going to focus mainly on safety of the higher doses of Gantenerumab during the OLE period, and I will spend most of my time talking about ARIA-E and ARIA-H. These are my disclosure. And before going deeper into the topic, I would like to briefly stop and spend some time to describe the escalation dose and how the process for escalation was done during the OLE period. First, each participant had to spend at least 3 doses at each titration step. Moving to the next dose was guided by a safety monitoring MRI, and if not ARIA, they will continue. I have to say, we started at a dose of 120 every month, and we escalated all the way to 1,500 milligrams every 2 weeks. That dose is 3 times higher than the dose that was used during the double-blind period. And I think that's something I wanted to highlight too. Now, 82% of the participants completed titration step to the highest dose, and the mean time to achieve the highest dose was around 19 months. And again, advancement to each dose was guided by safety monitoring and MRI, trying to pick early ARIA. Now, what I'm showing here and the image that you see on your right, you are seeing number of participants and the doses they reach. And you're also going to see ARIA-E highlighted as an E, ARIA-H highlighted as H, and then when we have both ARIA-E and ARIA-H, you will see a B. Now, one thing that I would like to highlight, overall frequency of ARIA-E in our cohort was 30%. That was 11% higher than the double-blind period, which was 19%. Most of the ARIA-E cases were observed during the higher doses. 28% ARIA frequency of those cases that reached to the higher dose, 6.8 ARIA-E frequency in those on the lower dose. Another element that I would like to highlight is frequency of recurring episodes. 8 out of 22 participants with ARIA-E had more than 1 episodes, meaning that they have recurring ARIA episodes. Most of the ARIA-E episodes occur during the 4-5 months of being in the higher doses. And again, one thing that I would like to highlight on this slide is that even when we tripled the dose for amyloid removal during the OLE, frequency of ARIA-E remains similar to the one described in SPOT AD trials and 11% higher than double-blind period. A few elements about general characteristic of ARIA, and I won't go into the details of specific cases because Dr. Ali will describe this later on. Most of the cases in our cohort had a multifocal and occipital predominant distribution of ARIA-E. Again, most of the cases, 26 out of the 32 episodes described during the OLE period were asymptomatic and identified during the safety monitoring MRI. And usually mean time for resolution of ARIA-E was around 60 days. Now, in terms of what are the main risk factors at baseline and OLE in our cohort? Well, what you are seeing here is that one of the main predictors of ARIA-E in our cohort was having higher burden of amyloid betas measured by PET composite, where one increase in every unit of SUVR meant an increase on ARIA-E of 1.7. And that was significant. I'm also showing other risk factors have been described in a sporadic AD trial that were not significant in our OLE cohort, but also there was a trend showing that those people that were more advanced in CDR had higher estimated year from onset as shown of the EYO or were APOE carriers. They also tend to have a trend to have a higher risk of ARIA, although this was not significant. Now, I'm going to briefly change topic and focus on ARIA age. The figure I'm showing on your right, you will see that I'm showing in the x-axis estimated year from onset, and this is a measurement that we use in our mutation carriers that it's help us to predict when it's the expected age of onset in these mutation carriers. In blue, you will see number of microhemorrhage per participants in the OLE period. And in yellow, you will see number of macrohemorrhage in the Gantenerumab observational trial. This is the natural history study where we follow these mutation carriers. Something that we observe both in OLE and in Gantenerumab is that once participants are more advanced into the disease, so one day past the estimated age of onset, we see an increase in the number of macrohemorrhage. With that said, frequency of ARIA age, especially microhemorrhage in the OLE period, was close to 37%. A significant number of the cases had ARIA age associated with ARIA E, but we also have cases that only had ARIA age without ARIA E during the OLE period. One thing that I believe it's also relevant to highlight is, once again, it seems that at least in the diet population, ARIA age increases as people progress into the disease, and also once they get closer to the estimated years of onset. We did not have any macrohemorrhage in our study, and it was only around like 2 superficial sideroses. Now, an element that we also discussed and we wanted to bring to you, especially that here we are showing data from the longest treated group in terms of CAN and amyloid removal therapies. Here I'm showing 2 groups. In dark blue, you will see people treated with GAN and no ARIA. In light blue, you will see people that were treated also during the OLE period with GAN but had ARIA-E. And I'm showing, you could see both graphs, that there were not a significant difference in terms of graded cognitive decline between those who had ARIA-E or worse functional abilities as measured by CDR sum of boxes. And I think that's also that we wanted to highlight as part of this comparison. Similar, and showing a similar graph, but now focusing on ARIA age. And similar to what I described with ARIA-E, there was not graded cognitive decline or in functional abilities as measured by cognitive composite or CDR sum of boxes. Again, highlighted in dark blue, people without no ARIA age, light blue, those with ARIA age. And with that, I would like to stop, but I would like to highlight a few take-home measures that I will want you to take. Number one, we saw that increasing the dose, tripling the dose during the double-blind period in this dominant inhibitor population is well tolerated. And frequency of adverse events is similar to the one described in sporadic AD trials. Once again, during the OLE period, we increased dose 3 times higher. However, the frequency of ARIA-E was only 11% higher than during the double-blind period. 30% in OLE, 19% in the double-blind period. Most of the cases or episodes of ARIA were asymptomatic and detected via MRI monitoring. And the other element that I would like you to take is that presence of ARIA-E or ARIA-H did not lead to a graded cognitive decline or decline in functional abilities. And again, most of ARIA cases in our cohort happen at the higher doses and usually during the first 3-4 months of being on those higher doses. Now, in terms of safety, what we are doing next, what are the questions that we'll be trying to answer in the longest treated group with amyloid removal therapies and during the ART trial? Well, number one, what is the safety of changing from one anti-amyloid therapy to the other one? Number two, what is the long-term effect of using these amyloid therapies? What are the considerations we need to have during GAD periods in terms of safety and monitoring ARIA? Another element that our trial will be key to answer, right? What is the impact on drug safety in asymptomatic individuals, right? And also, what is the effect, right, on the continuous amyloid removal on amyloid related imaging abnormalities? What happens once people get to no evidence of plaques in terms of ARIA in this population. And those are some of the questions that will be answering during the R trial. Again, I will save questions to the end, but this is what I wanted to share with you in terms of safety during the OLE period. And again, I'm presenting on behalf of the DIAN safety monitoring team that tracks and help keep these participants safe.
So next is Dr. Ali Atri from Banner Health. Dr. Atri is the project arm leader for the Gantenerumab open label extension study. And what that means is that he is the individual who handles all individual medical and side effect cases, and he's prepared to show several instructive cases from the trial, individuals, their time course, and how they change. Ali?
Thank you very much. Hi, everybody. It's a great honor to be with you to share some insights about what we found out. Please refer to the online program for my disclosures. I'm involved with all companies, including plaque-lowering companies, Roche, Genentech, Eisai, Biogen, clinical trials from Lilly. So as you know, as you heard, ARIA is pretty ubiquitous in amyloid plaque-lowering drugs. Our understanding of the mechanisms of nature is incomplete, and we understand from the sporadic AD that many of the risk factors are related to drug exposure, ApoE carrier status, and amount of CAA. As you heard from Jorge, the PIB-SUVR may be another major factor here. But there's a wide spectrum of presentations for ARIA, both radiologically and clinically, and this can be mitigated through selection and individualization, and this is what we did. Our aim was to really share some of the insights from a few cases. Most of them were currently unimpaired and MCI, and show how we took this really, really incredible privilege and incredible, awesome responsibility that the patient's families put on us. Seriously, how we coordinated to individualize this, and the incredible efforts of the site PIs to talk and in a very patient-centered way to individualize the titrations, and how we managed to do that in this trial. So this is the first case is one of recurrent ARIA, 6 episodes, and this person came in 2014 into the double blind. As you can see, there were CDR 0, MMSE 30, EYO at that point was negative, they're E4 positive, and they had no microhemorrhages. And during double blind phase, they up-titrated to 675. And actually had their first episode of ARIA that, in retrospect, probably was mildly symptomatic because they had said a while before, that their balance was off when they're putting their shoes on and standing up. But they had one focus of ARIA-E, that's occipital, and again, you'll see this recurring over and over, just like Jorge said. So much of the ARIA that we see is occipital. They were paused, ARIA resolved, they resumed at the same dose, and ultimately went up to 1020 Q4. Had their second episode, this time left occipital. Again, these are not large areas, 29 millimeters, for example. And you can see their EYO is now becoming positive. We paused again, and ultimately it resolved, and we were able to actually up-titrate all the way to 1200 Q4 through the end of the study. And at the end of the study, there were EYO positive and a CDR negative. During the pause, the gap period, and before starting OLE, as you can see, now they're creeping up. They're becoming symptomatic. Their CDR is 0.5, EYO is now 3.3, SUVR is 1.56, sum of boxes is 1.0. Over the next 1.5 to 2 years, we increased their titration all the way up to 1020 Q2, so double the dose where they ended, well, not quite, but close to during the double blind. They had their third episode of ARIA-E that we managed with 2 foci. But what you notice by this point, after 1.5 years, now their CDR is 0 again. MMSE is 29, and their EYO is almost 5 years out. We paused again, individualized the treatment. We resumed at 1020 Q2, and ultimately were able to increase them to the highest dose of 1500 Q2, where they ended up having their fourth episode of asymptomatic ARIA, which increased a little bit over time. We paused again, and it resumed. I'll show you some pictures of the episodes 5 and 6. So we resume with down titration. So we're continuously talking to them about whether they should continue or not. Do we know the knowns, the unknowns, the risks? And some of these patients are incredibly adamant that they want to continue. And with a shared decision making with the site, they were continued. They actually went down and then resumed all the way up to 1500 Q2 again, times 6 doses, had a fifth episode of ARIA, two foci, that then grew to 3 foci, a total of max diameter of 60 millimeters. They had 3 small microhemorrhages, which resolved again with holding. And you can kind of see a flavor here of the ARIA over time, and as it resolved, sort of going from left to right, that's a temporal order, appearing and resolving. So we down titrated again to 1020 Q2 times 6 doses, and they had a baby little foci of ARIA-E 5 millimeters. Again, asymptomatic. Dose was held, and it resolved. And one thing I want to show you is, and at that point the OLE ended, is that if you look at their MMC at the end is 30, CDR 0, their EYO is over 6 years out. And they came into the OLE actually symptomatic. So cases 2 and 3 that I'm going to tell you really quickly about are cases of delayed onset or late onset ARIA. So, and these are cognitively unimpaired individuals who are ApoE4 negative. So as Jorge said, usually at the highest doses, we saw ARIA within 2 or 3 months. And that number of 4.7 is skewed by folks like these folks who actually developed ARIA much later than that. So this person you can see came in at 2015. They were, there are many years. They're almost 14 years EYO negative in 2015. Went through the double blind, came into the OLE. At start of OLE, they had 2 microhemorrhages to begin with. So as Jorge mentioned, you have baseline sort of non-ARIA related background rate of MCHs, and that does develop in individuals. So we up-titrated them, and all the way through for the next, in almost 3 years, and they came up 2.5 years to the max dose of 1500 Q2. They actually had 17 doses at that level before they had ARIA. Again, what does that say for clinical trials or clinical care? That's kind of interesting. So they had their episode. It was asymptomatic again, just one focus with some superficial siderosis. And you can see the picture there. The dose was actually paused just times 2 doses, and it resolved. Both the ARIA, and you can see on the bottom right there, the superficial siderosis tiny area. We resumed at the 1500 milligram Q2, and the OLE ended, and they were CDR 0 still, and their EYO at that point was still negative, so they weren't expected to be symptomatic. This one's an interesting one because they actually had rapid resolution of ARIA with IV steroids, but we did the taper very quickly. Remember, these folks are working. They're oftentimes in their 40s. In the middle of their careers, they have kids, they have families, and so they didn't want to be on steroids for too long. And with that, they had a rebound of actually when the taper was too quick. And then we gave them oral steroids, and it resolved. So I'll show you this here again. And again, these people were not hospitalized. These are all folks who we managed as an outpatient. So this person came in at 2015 to the double-blind CDR 0, EYO -9, came into the OLE unimpaired with no microhemorrhages. We up-titrated them over the next few years, and they had received already 13 doses at the max 1500 Q2 when they developed actually mildly symptomatic ARIA. So mildly symptomatic, that was the symptomatic grade, but really the grade of the ARIA itself was pretty severe because they had 7 foci. and one foci of superficial siderosis. They continued to work. It didn't cause their any issues. They had mild headache and brain fog. Their max dose was diameter was 90 millimeters total diameter. We paused the dosing, but it increased. So it went from a max total diameter of 90 to 133. It's interesting how ARIA resolves, because even in that phase, 2 resolved, but then 2 new came along. At that point, we really made a discussion with them, hey, it's really time for us to not let this go the wrong direction. So let's do some IV steroids and a short oral taper. We did that, it resolved, great. But the next MRI, it rebounded. And so that's when it rebounded. There were 5 foci, of which we ended up had 3 of them recurred and 2 were new, but no ARIA-H. So this time we gave them oral steroids at a higher dose for longer. And we kept going, and it resolved. And at that point, we switched to a lower dose, and OLE ended, and at the end, they were continued to be unimpaired. And the last case I just want to show you is somebody who came in 2015. They were CDR0. EYO was already positive. And by the time they came into the OLE, their CDR was now positive. So their symptomatic CDR sum of boxes 1.5, global was 1.5. They had 1 microhemorrhage in the left temporal lobe, and they were up-titrated all the way up to 1020 Q2, up to 6 doses. They had their first episode of ARIA-E. They had 2 foci, the familiar areas, occipital areas, and you can kind of see them there. We paused. They resolved. We resumed at the same dose again, and we had reoccurrence with 1 microhemorrhage, and we paused again, and it resolved again. And at this point, we down-titrated to a lower dose, and what you can see is something that's very, very interesting, is that if you compare their MMSE now, EYO almost 12 years. So 12 years from expected year of onset of being symptomatic, they are asymptomatic. CDR is 0, MMSE is 29, and they came into OLE a few years later before symptomatic. So in conclusion, we took a very person-centered, shared decision-making approach that really prioritized a respect for autonomy for these individuals who really know, in many cases, what their risk is, having taken care of their parents, and did individual risk assessment benefits with them. This population, I find, having worked with them for over 20 years, oftentimes has a higher risk tolerance to gain either potential benefit, even though we don't know what that is, or to contribute to science in many ways. It required really a close partnership, and with proficiency and a lot of work. I would say don't try this at home. I see Dr. Master sitting here. How many times were we on the phone at 2 or 3 in the morning with your staff, emails? But it required that amount of dedication to get these people through, and fortunately, they did well. We learned that ARIA can really be late and delayed, even in unimpaired individuals who are E4 negatives. It can often recur and be multifocal, sometimes in the same areas, including occipital, that we can manage it with really individualization and titrations up and down. We erred on the cause on the side of pausing and resuming doses, sometimes lower, and having a lower threshold for steroids. I honestly believe that when all said and done in years to come, we'll find out that in many cases, steroids will help in cases where things are not going the right direction. And we just really need to take this responsibility really seriously and remain humble about all the things we don't know while we're still hopeful. And this is where art comes in, to be really thoughtful and careful, to think about individualizing these N of ones, to think about risk-benefit calculus in the individual cases, respecting autonomy, and hopefully this will teach us a fair bit more about what to do in clinical trials and also in clinical care eventually. And again, a big shout out and thank you for the patients and families and the staff. Thank you.
Thank you very much, Ali. Our next speaker will be Dr. Laura Ibanez from Washington University. Laura is the biomarker core leader for the DIAN-2 program, and the title of her talk is The Impact of Gantenerumab Amyloid Removal Therapy on Established Alzheimer's Disease Fluid Biomarkers.
Thank you. Can you hear me? Yep. Okay. Okay, we're having some trouble here. Okay, I'm going to talk about the biomarkers. What is the thingy?
Sorry.
Okay. I'm going to be talking about how the biomarkers change during the treatment with gantenerumab in the DIAN population. Before starting, for the biomarkers, we will be including some of the data that was collected and analyzed during the double-blind period. And basically what we saw during that period is that the amyloid plaques were reduced. The biomarkers were also going back to what we could consider normal levels or trending towards that direction. The OLE, or the open label extension on OLE, was right after the double blind with 1 year gap, and basically contained higher doses of the drug. To show you how the biomarkers are changing, I'm going to present you a new way to look at them called Centimarker, and the preprint is available. You can check the QR code here. And basically, this is a need of the field in which we cannot compare or the biomarkers or compare the relative changes side by side. So by transforming them, we can put them in the same scale, and so they can be compared, and we can see how they change in the same level and evaluate as a whole thing. They are basically, we can look at them as percentile values that go from 0, that will be the normal or the general population, towards 100, that will be the most abnormal level in the analysis. We collected for the OLE and the double-blind period CSF every year in fasting conditions, and it was processed immediately and frozen for biomarker assessment. The doses have been presented previously, so I'm not going to cover that. For biomarkers, we used immunoprecipitation mass spectrometry to measure A-beta 40 and 42 to make the ratio, total tau and phosphorylated tau to 17. Those were transformed to centimarkers for easy comparison. So that's what we expect in the natural course of the disease. All the biomarkers will go towards abnormality with time, especially past age at onset. So the main question is, can we change those trajectories using amyloid removal therapy? Short answer is yes, but I'm going to show you the changes of 3 of the main biomarkers. Before we dive into the results, I want to walk you through this graph. I'm going to show the exact same graph for the 3 biomarkers. So in the y-axis, there is the centimarker. In all cases, going down is going towards normality. It's what we want. In the y-axis, you have time, and the first box shows the double-blind period. There is a small gap year, and then the OLE period. In blue, we have the people that have been treated with gantenerumab the whole time, from the double-blind to the open-label extension. In purple, we have the ones that were placebos during the double-blind period and were treated only during the open-label extension period. And in red, we have those that were treated with solanezumab during the double-blind period and were switched to gantenerumab in the open-label extension. So as you can see in this graph, for the amyloid beta 40 to 40 ratio in centimarkers is that we start at 0, which is, sorry, I forgot to say that the y-axis, it's change, it's the change. It's not absolute value. So we start at 0, there is no change from baseline, right? Baseline, and how they evolved. And you can see clearly that the ones in placebo go up, so towards abnormality, while they are not treated with gantenerumab. And the moment we start treating them, they go down towards what will be normality. For gantenerumab treated patients, we see that they go down constantly during that time. And for solanezumab, there is a high slope during the OLE period. And it is very exciting to see that what I've showed you with the amyloid 40 to 40 ratio, it's also true for total tau. We also see how it decreases, especially in the higher doses. But for biomarkers, we know that the ratios work better sometimes than the comparison of absolute values. And so when you look at the p-tau to 17 ratio, it's extremely clear how things, what's happening in the placebos in purple, going up during the double blind, and then towards, there is a decrease in p-tau to 17 during the OLE. Same for the Gantenerumab, and exactly the same for solanezumab. So with that, we can conclude that during the Gantenerumab treatment, the CSF biomarker trajectories improve significantly, going towards what we expect to be, or what we define as normal levels. Biomarkers are informative under amyloid removal therapy. So when we have the therapy present, they behave as we expect. We still track the same information, which opened the possibility of non-invasive drug response monitoring complementary to the imaging. So we can have more intensive monitoring. In patients that were administered Gantenerumab during the, only at the OLA phase, you have realized that the slopes are higher than those that were treated with Gantenerumab during the double blind and the OLE. And we think that slope is more pronounced probably because they started at more abnormal level when we increased doses. Overall, biomarker trajectory suggests that there is a benefit to treat with amyloid removal therapy in the DIAD patients, and we will see the continuation of that hopefully in the ART study that has been already described. Thank you very much.
Okay. Our final presentation will be presented by Dr. Tammy Benzinger, who is the imaging core leader for the DIAN-TU.
Thank you so much. It's really an honor to be part of this study and to be able to conclude with the data in this final part of the talk. As was mentioned earlier, our disclosures are online. And this study was done in partnership with Roche and also with Eli Lilly. And as an imaging person, I have multiple relationships with multiple companies, et cetera. Oh, and they're actually shown here. Okay. So just a reminder as we wrap up to kind of set this in context. We have the trial participants that we've been talking about, and then we also have our observational studies. So these are the family members who were not in the trials, and that data is also part of our worldwide consortium and gives us the background information to tell us what changes we expect to see in these mutation carriers in the absence of treatment. And just to say, we have a really, really rich data set that we're collecting in the observational studies that we use to inform what's happening in the trials and also in the trials. And this includes amyloid and tau PET, but we also have measures of brain function such as FDG PET and blood flow like ASL and resting state fMRI. So just incredible resources to try to think about globally what's happening in the brain in this disease and also in the setting of treatment. As was discussed earlier there, how we've had kind of multiple different phases for the treatment study. And so what I'm going to be focusing on again, as we've heard earlier, is what happened in that first double blind that we call the 001, where we had Gantenerumab and solanezumab. Then we have the gap period, and then what happens when everybody goes back onto Gantenerumab with a focus on what do we see in the imaging features. And just to give you some examples of what this looks like. So the first case I'm showing you here is an individual participant who started out on the placebo in the 001 study. And their amyloid PIB-PET scan, you can see they actually started out with a negative amyloid PET. They were on that placebo, and by the time they entered the opportunity to go onto the Gantenerumab treatment, they were already amyloid positive. Similarly, they were already tau PET positive at the start of that open label extension, and they unfortunately had increases in tau PET. And sort of what's happening with tau PET and these other imaging markers is one of the most important questions we're trying to think about and focus on in these studies. By contrast, this is another individual who actually starts out amyloid positive at the start of 001, but is on treatment with Gantenerumab, becomes amyloid negative. Our first tau PET that we acquired is at the start of that open label extension, and they actually were tau PET negative, and they remained tau PET negative. They further cleared amyloid and never developed tau PET positivity. So really intriguing findings when we start to look at these individual patients and cases in the participants. So again, the participants we're looking at are both the double-blind group that went on into the open label, so an N of 73. We are using participants from our observational studies as a really important comparison group, and some additional controls from our other arms of the TU. And then the imaging measures that I'll focus on today are going to be that amyloid PET, which used Pittsburgh Compound B, our volumetric MRI measures, so we're doing a standard 3D-T1 sequence with free surface segmentations, and then our tau PET agent in this arm was fludarabine. And for the statistical models, as you've seen along the way, we were using the MMRM, and then a lot of the images I'm going to show you where we're digging into the data are actually showing you with a mean and standard error for visualization. So just by way of review, this is the same data you've now seen a couple of times during this presentation, but I think it's really important to understand this in order to understand what's going on. So if we take a look at figure A, that's during that double-blind period. And so if we take the people with their baseline normalized PIB-PEB composite, we see this separation that happens, the decrease on amyloid PET in that first group. And then if we take the open label extension group as a whole on the right, we also see this decline on that PIB-PET SUVR that's happening on the whole, across the whole groups. You can also see, if you look carefully on the bottom right, we also looked a little bit at what's happening with dose. So that early part of figure B, you can see the slope is more modest, and then when we have the higher dose, we actually have a more significant decrease in slope that's happening, resulting in a 0.35 SUVR reduction during that open label extension year 2 at the higher doses. But I think we can look at this a couple of ways and look at it in more detail. So now what we're looking at here, and this is very similar to the way we just looked at those centimarker results. So if we take the amyloid PET over time, you can see that in that first double-blind treatment arm, the Gantenerumab group goes down, while the placebo and the solo groups were both going up. During the gap period, if we look at where they ended the double-blind and start the open label, there are some small increases occurring in all 3 groups that are really similar. And this is very important because we actually didn't know what we were going to see. Were people going to rebound and have a crazy high amount reaccumulate quickly? We don't actually see that at all. It looks very similar to what happens if you don't have the drug or if you never had the drug. And then when we look at the open label extension, we see that the decreases that are happening in the Gantenerumab group are relatively modest, but if you look, they're actually starting quite low when they go into that. The decreases that happen in the previous placebo and solo groups are very dramatic, and these are also dose-related. This is just looking at it kind of the same way with renormalization for that open label extension, where you can see those decreases happening across those 3 groups. All right. This is the exact same data, but I wanted to also show it in centiloids. So the reason I showed you in SUVR is that was the way our trial was designed and specified. But since we started this study so many years ago, the field has changed a lot. And so I think looking at it in centiloids is also really important. And so here you can see that that centiloid change that we're looking at overall, you can see is going down, for some people, as many as almost 40 centiloids drops by the time we get to the end of this study. And so just to discuss these amyloid PET results, we see that this amyloid plaque removal was dose-dependent, with many participants, about 30%, reaching completely negative levels. And I think really importantly, that gap period did not result in any significant amyloid accumulation above what we would have expected if they'd never seen drug before. And again, this is just that example participant we started with. Starts out with an amyloid positive scan, cleared out a lot during the start of his treatment, and then even more by the end of the open label extension. So, but we do have other measures, and I think it's important to look at those in comparison. And unfortunately, when you look at the volumetric MRIs, we're seeing the same finding that we've reported and others have reported for all of these drugs, which is despite having this really robust effect on the amyloid plaque clearance, if we look at the hippocampal volumes, we're not seeing statistically significant differences between the treatment groups and the controls. On the other hand, the opposite is also true, that we're not seeing bad things happen, right? It's basically just doing the same thing, and we're not seeing anything that looks worse than what we would have expected if they hadn't been on the treatment. We also looked at cortical thickness in the precuneus, so this is a really important region for us to look at for amyloid accumulation and also for volumetric changes. And again, we're not seeing any statistical differences between the groups, regardless of which treatment they were on, whether for better or for worse. They're just continuing to do that thing. Tau PET was very interesting for us, though. When we start to look at the Tau PET results, what we start to see a hint at is you can see really nicely on that top panel is that group that had Gantenerumab from the start, a lot of them did not become Tau PET positive. And even though they have maybe a slight increase during that gap year, they remain very low across this whole period. And that's in contrast to what we saw going on with that placebo group as well. So this is something we really want to look at in more detail, and especially at that individual participant level to understand what's happening. And so just, sort of for summary, here are those two participants again. So the person who started out on a placebo for all of those years, even though they have amyloid treatment later on, by the time they get it, their Tau PET positivity is already there and continues to increase. Whereas here's this other participant who never became Tau PET positive for the entire course of the study. And so, with that, we were very interested in looking at that rebound effect of the increasing amyloid accumulation was very minimal. They did go up, but not more than the other groups that we were looking at. And that amyloid reduction on PET was robust across all of the groups, including the people that had previously been treated. And in fact, there's a suggestion in this imaging data, a trend, that perhaps that prior exposure to solanezumab may have responded more robustly to the Gantenerumab to follow. So that's something we definitely want to follow really carefully as we start to think about what implications this might have for clinical practices in the future, where we may be having patients that switch between different treatments. Some of these individuals did have complete clearance of their amyloid PET, about 30%. And the Tau PET findings are really variable, but we have individuals who really don't ever accumulate the Tau PET positivity, which is really important for us to follow up on. Again, this is the link to that preprint if you wanted to see some of these summary measures in more detail. And then, so we're planning what can we do next with this group? So incredibly valuable data set. We really are interested to know what really happens long term for these people who've completely cleared their amyloid from the brain. What's going on with tau PET and why? How can we tease apart what we're seeing here? We've seen some great information here on ARIA and its relationship to cognition, and how does that also relate to all of these other imaging features that we have? And then finally, this effect of changing drugs. It's definitely a real-world scenario for our patients in our clinics, and this is data that can directly, I think, be helpful to us as we start to think about that. So just in conclusion, we want to thank again all of the cores, the collaborators, the sites, and most importantly, the families, both for the trials as well as for the observational studies. And all of this can't happen without all of the components being there. So thank you.
Okay, we're going to start the discussion panel now, and we have two additional panelists joining us in addition to the speakers. One needs no introduction, but Maria Creo joins us as a panelist, and Maria has been a longtime advocate and supporter of the Dominantly Inherited Alzheimer's Network, and especially the families, and has really been a wonderful supporter from the very beginning, helping us get started pre-2012. So I want to call out Maria and the Alzheimer's Association, GHR, and the other funders that made all of this possible at the very beginning when it was quite precarious to start. So can we give them a round of applause? And Greg, would you introduce Janice?
Yes, I'm happy also to introduce my colleague from Roche, Dr. Janice Smith. Janice has been the formal global development lead for the Gantenerumab program during the graduate studies and currently is the global development lead for our new Trontinemab program. So welcome, Janice.
And as we get started on the questions, if you all have questions, please make your way up to the microphones. You can ask your questions, and Greg will field the questions in the audience, and then I will field other questions. Right. So come on up to the mics, and we can get started. Before we get started, I'm going to just make one other comment of thanks and recognize Roche, Lilly, and all our other partners, our pharma partners over the years, for being really outstanding contributors in these kind of trials that are very difficult to do, but to run a trial for more than 10 years and to stand by it and always make the right medical and ethical decisions really says a lot, I think, about the developers of these new treatments. So I just wanted to call that out. Okay, great.
So it looks like we have a question up front. If you could please state your name and affiliation, that would be great.
So I'm John Ringman of the University of Southern California. And that was the first thing I was going to say is what's to be lauded so much is the commitment of the investigators and the participants over the decades. So that's very impressive. My question is, has anyone attempted to look at the effect of the genetic heterogeneity on these outcomes? Because these different mutations act differently. The age of onset, the rate of decline, the likelihood of having CAA. I know it's hard with the numbers, but has it been attempted to take into account the specific mutation that they have?
Yes. Maybe, which panelist wants to take that, or I can take that? Jorge?
Yeah, I could briefly refer on terms of frequency of ARIA-H and macrohemorrhage. And as you mentioned, this is kind of like there is a difference between these mutations and how prone they are to accumulate macrohemorrhage, right? For example, the Jalisco mutation, that's one specifically that tends to have macrohemorrhage, just part of the natural history of the disease. And those are one of the considerations we usually also have when seeing some of these mutations. That's just one example, right? In the other element in terms of age of onset and EYO, something that we have been kind of like really focusing using is how we use the age of onset across these different families, right? Getting that right estimated age of onset across different families living either in US, Europe, and getting that to bring that into the heterogeneity that we tend to see.
Great, thank you. Next question, I think I see Nick on the side. Yes.
Yeah, thanks. Yes, Nick Fox, UCL, and for the audience's sake, I've been a Diane site PI for forever. On behalf of the families that we look after, this is just fantastic to see this going forward, but I'm sure lots of people will echo that. I had a question about what I felt was very reassuring results of that Jorge presented about the ARIA not being associated with a clinical worsening. And it would have been, particularly with the design of this study, it would have been reasonable to expect a worsening, because I don't think ARIA causes cognitive decline, but the people with ARIA, as Jorge, you pointed out, were the people who started with the highest PIB, and the higher PIB is also more likely to give you a cognitive decline. So did you adjust for that? Because if you didn't, that's actually very reassuring.
No, that's a great question. In the analysis, right, we did not adjust for PID-PET at baseline in the ARIA results that I showed. That's something that we could definitely take back and take a look. Yeah, I would do say that as I shown, right, having higher PID-PET SUVR at baseline was one of the main predictors of ARIA, right? Which I think it's really important when we think in terms of treatment gaps and restarting. But we haven't taken a specific look on that, but we could take it back, and I'll get back to you on that answer.
Let's see, I think next in line is the gentleman in the far back.
Oh, thank you. This is Chen from Washington University in St. Louis. I have a very specific question. So, have you guys ever compared the accumulation kinetics of amyloid in the gap year, also in the time you withdraw the treatment due to ARIA, comparing with the early year accumulation of A-beta? So, because I would imagine with pre-existed amyloid deposition, during that phase, the accumulation of A-beta may be changed? I don't know.
Yeah, so I mean, I think there are a couple of ways to look at that. If we look at it from the PET perspective, where we can look at the rates of accumulation, what we're seeing is that the rate of amyloid accumulation for this cohort, whether they're on placebo or in our observational studies, is very well established. And during that gap period, it looks like they're matching that pretty well, and not accumulating faster or slower that we can detect significance for.
Okay, yeah.
For the CSF, that's I think a separate question that could be addressed.
I think if the questions regarding to when they had ARIA and they were paused, the PETs don't happen at that frequency, so we don't have that answer. Okay. The CSF doesn't happen to the frequencies. What was collected and can be answered is blood. So, blood does get collected. As soon as there's ARIA, that gets collected, but we don't know the answer to that yet.
Okay, yeah, thank you.
And I think we have one more question in the middle.
Yes, thank you. So, Michael Rosenblum, University of Washington. So, anyway, Ali, I thought your presentation was really fascinating, and it clearly shows you how an individual case can teach you so much. And I was struck by that case you presented of the late onset ARIA-H. And, when you look at the literature, you think you're out of the woods if your patient's not ApoE4. But, at least with the sporadic population, in my experience, I've had some cases of ARIA-H that occurred later on after receiving the drug. And then kind of my research led me down this rabbit hole where, some of these patients who are ApoE2, they have an increased risk
of hemorrhage in the setting of amyloid angiopathy, and these individuals happen to be ApoE2 positive. So I just was wondering, in your experience, if you've seen if any of these patients, in particular the one you presented, was ApoE2 positive.
I have to look into that, Mike. I don't know, but I think you're totally right. And obviously, the folks who come into the clinical trials generally, right, they have less than 5 microhemorrhages, et cetera. But when we think about they're out of the woods, maybe what you end up seeing in many of the trials is that there's still 10%, up to 10% ARIA that happens later after 12 months, and even in those trials. So what's the nature of that? We don't understand, but kind of goes back to the genetic heterogeneity and all the other factors that go into ARIA. So, but I can look into the A2 and let you know.
Great. We have a question along the side.
Monica Crane, Tennessee Memory Disorders. I have a question about the real-world clinical management of ARIA-E. So we are a nonprofit clinical practice. And how do you manage asymptomatic ARIA-E? What is a threshold for steroid use? We have sort of had a variety of ways of managing it, but in some cases there's not quickly resolving ARIA-E. Are any of you using steroids for asymptomatic moderate cases?
Yeah, I mean, I think we all need more guidance on that for sure. And for disclosure, I was part of the ADRD therapeutics work group that puts out some of the appropriate use recommendations. And there's no formulaic answer. There's going to be a little bit more guidance on maybe Maria can say something about that ARIA. But it depends, again, individualization about where their trajectory is, what their risk factors are they diabetic, what is the course, where is it going? You mentioned asymptomatic, asymptomatic, and it's, a few spots, and the next one, it's starting to blow up. I have a lower threshold personally because I don't want the CARI sort of course. But we don't know that, and we need to actually study that, I think.
I think maybe if I could add, this is one of the reasons why we launched ALZNet, because we want that data. I will tell you that we have an ARIA working group that has reconvened as of March of this year, and we've got some members up here on the stage. But that said, we will be publishing 2 papers. The first is really an update on the original ARIA, because we know so much since 2011 when we put that working group together. But the second paper that will come out, we hope will have data from the clinical trials, because we will have real-world evidence, but that's going to take a little bit longer to come in. The trial data is really going to be up to our partners, our industry partners, to share that information with us, which when we've asked that in the past, the answer was no, because their programs were still ongoing, and they didn't want to jeopardize their programs. And we understand that, even though I wish things were different. I think we're going to go back and ask again. And so we hope that we will have a paper with some data in it and be able to compare across programs. I'm just not sure we'll get there as soon as we would want. Otherwise, real-world evidence is key, and that's why we're asking everybody to contribute that data to ALZNet. That is the only way in which we're going to be gathering data across programs. Thanks.
Great. You have another question in front.
Second question.
Yes, you do.
So there's at least some literature out there suggesting that if you're predisposed to CAA, that the likelihood of you having hemorrhages is increased if you have hypertension. Does someone look at, has hypertension levels of blood pressure been looked at in these studies, and the risk of ARIA-H or E, I guess?
Not on the double-blind in the early data, right? During the double-blind period, we took a look on that one, right? And again, it was not a statistical significant, but it was also a trend, right? Where having higher mean blood pressure at baseline seems to be predicted, again, not significant. And again, this also depends on the number of macrohemorrhage. That's something that we do want to take a look during the early period and also see how we could monitor that as we transition to ART.
Yeah, and John, I believe Lilly presents some of that data at CTAD, where maps of more than 97 were were associated with that. And I can tell you my clinical practice, we definitely at Banner will look at the blood pressure, and that's part of the management before to even make sure that folks are appropriate.
Another question in the middle. Yes, you.
My name is Kim from University Pacific, and first of all, thank you for your great presentation. And I am a family member of Alzheimer patients on another, the amyloid plaque lowering agent, and he's intolerant MRI is because he has the panic disorder around it, and then they try the anxiolytic agent, and he couldn't still tolerate the MRI, and also that they tried the open MRI, but that the ARIA is kind of on the borderline, so they really need the full MRI. So I'm wondering, what is your experience with MRI intolerant patient in your trial, and how did you manage it, and do you recommend any aggressive intervention about propofol use or something like that?
All right, so I'll try to take this one. So the first question is in the context of the clinical trial, what do we do if they can't tolerate an MRI? So from the beginning, I showed we have all of these wonderful sequences, resting state and ASL and everything else, but we also have a short protocol. Because if somebody's having trouble tolerating the MRI, whether it's because they're having symptoms or claustrophobia or whatever, we always try to have a shorter version, which unfortunately for us is still maybe 20, 25 minutes, and you have to hold still. So if you couldn't, you basically for the trials, you have to be able to get at least the safety MRI data. But flipping gears, what happens with patients? So I'm also a neuroradiologist, and we have patients in practice, and I do a lot of work with the American Society for Neuroradiology on this. And I will say there are now new protocols developed working with Siemens and GE and Philips that are only 10 to 15 minutes for getting those safety MRIs. And there are sites that'll also do sedated MRIs for specific populations. There's also a lot of outreach going on looking at other alternatives to getting the MRI, whether you said you looked at open MRI. I know there's some things going on with low field MRI as well, other measures. And then when I look at our own practice, we have other reasons people can't get MRIs, like maybe it's a pacemaker or some other device. And we've been working really, really hard to develop radiology guidance on this about when is it okay maybe to use a head CT? When is it okay to use some other technology in order to not have the ability to go in a 3T MRI for an hour restrict you from getting access to a therapy? So there's no straightforward answer for that, but I think it's definitely something that we all need to be thinking about and working on.
Nick, it looks like you have a comment on that, or another question.
A brief comment on that, but a question I was going to... Yes, I think it's really encouraging that the ultra-fast MRI, I think maybe we can be getting even... We run a protocol at our center, which is a sort of 4-minute safety protocol. We probably could get it down even faster. But I was going to, if I'm allowed a second question, to the story, not just of this study, but of the field, has been of us starting probably rightly slow with quite low doses on a sort of cautionary start, and then as we've seen, and I think the data really show it, the benefit of higher doses. Could I ask the panel to speculate about whether we have been similarly overcautious in the restrictions of what we will allow people to go in, like 5 microbleeds being different to 4 seems terribly arbitrary for a start, but also it's something that hasn't moved with the time and the experience. And I really, that also is a nod towards, particularly in this population who are less frail, very motivated, and the respecting of autonomy and patient-centered decisions. could we not take, and I'm sure the working group will address this, but pending that working group, I'd be interested in your opinions. Should we be less cautious?
I can just start with what we're thinking about in the working group right now, Nick, and then perhaps our clinicians here can expand on what they're thinking. Because Ali in particular was a part of the appropriate use recommendations for the first 2 drug approvals, and I believe for the third that's coming, and can speak to even more conservative approach there than what's in the FDA label. But in our ARIA working group, if you remember back in 2010 when we were putting that together, and then 2011 when we published, we didn't know much. And we brought together not only the animal work that had been done, but we brought natural history of aging, right? That happens, and what happens with the drugs that we had, the information we had available then on the clinical trials, which was primarily Eli Lilly's Expedition 1 and 2. So, and we all know that ARIA there is probably not much, right? So we didn't have the best data. We took a stab with what we knew. To be honest, we know so much more now that I don't think we're gonna be more flexible in a recommendation. If you really take ARIA as seriously as we need to, and what we've seen our clinical trial participants go through, and we've seen reported deaths and very serious reactions, it is going to be difficult for our field. And I would even ask you how you would then reflect on translating this in Europe, as there is an abundance of caution there, as we saw from the EMA decision recently, and maybe the UK will be different. I don't know. We still have hope there. But it seems to be that we're moving towards a lot of caution. Ali, anything you would add?
Oh, sure, yeah. I would say I can't speak for the whole ADRD therapeutics work group, but I know that the last few AAICs we've had featured research symposiums, and I think this has been voiced, that the tack was to start off being more conservative, where there was really, until there was more definitive evidence. And then as evidence accumulated, those things can be re-examined and adjusted. Partly because you're taking stuff from clinical trials in a very, very well-resourced, proficient, groups, and you're putting into clinical care, and you're changing multiple variables there. And I think I would say even in the U.S., there really is a huge resource implementation gap going from clinical trials to clinical care. And so falling on that side of being more safe. Mm-hmm. And there are, again, things like Diane-2 and ART and other studies that need to examine some of those things. So and the data for that to be shared. And I think I'll second what Maria said. We really need to have data from companies and put it all together to understand the nature of ARIA and to be able to look at the totality of the evidence before there can be recommendations for more relaxation of those things.
And on Tuesday, ASI will be presenting the open label extension work, and so that we'll take a look at not only what that happens with the clinical outcomes, but also with safety. That'll be an interesting presentation in the afternoon.
Okay. Randy, I believe we have a few online questions.
Yeah. I'm going to add a bit to this. In our study, Nick, as you pointed out, we did not have a strict cutoff going into the open label extension. And so some of the people who entered Gantt for the first time had much higher microhemorrhage counts or would not have qualified for the cutoffs that were chosen for the late onset sporadic Alzheimer's disease trials. So this is really some of the first evidence of what happens when people have higher microhemorrhage counts or have multiple bouts of ARIA. And how those people do, and I think it's informative, and it'll be useful. It'll also be useful to continue to follow these people over time, as we're planning to do in our amyloid removal trial application, to continue to see how these people do when they have higher microhemorrhage counts or they have other things that might have been an exclusion in the trial. I think the answer so far is that you can't address this until you study it, because you simply don't know what is the difference between 4 and 5 microhemorrhages, or 7 or 12? And the other thing to add here, and Tammy can speak to this, clinically, we've run into issues because these metrics are all a factor of how you measure them. And depending exactly on what kind of sequence you use, what kind of scan you use, how often do you follow people, right? Just the frequency of MRIs changes what you see, right? On our observational cohorts, we don't get scans every 3 months and follow them very carefully. So we're seeing things in the trial that we typically don't see. And so the challenge there is the data that has existed before in terms of CAA and side effects may not be directly applicable to when you're very carefully monitoring people. And I think it's a very important and open question because it matters to individual patients who are on that threshold or who have the ARIA, what to do next. And because our families and patients typically are so driven to contribute information, and they make the point, look, what alternative, I'm going to dement, I'm going to die from this disease, and it's going to be really bad for me and my family. Why would you want to stop me? Why would you not let me continue because you're seeing something on an MRI, but I feel fine? And what's the response? The response is, well, we don't know. And so we have a concern, a physiologic, a theoretical concern. But that was some of the art, I think, of what was applied in this trial by the Project ARM leaders and the medical team that really enabled us to carefully go through. And I hope we've been able to share some of that in the case studies that were presented and the safety. But I agree these are really important questions.
Yeah, I mean, that was, Randy, exactly behind my question. I think, seeing the families, individuals so disappointed, they got a few more microbleeds to exclude them. And I think it was, and I'm not sure, I think more needs to be made of the fact that there was this approach of allowing people with more than 5 microbleeds to get treated, because that is the way we build up evidence about what is really worrying and what is less worrying.
Mm-hmm. Okay. I'm going to field a few questions that we have here, and then, but please, if you have questions, you can go up to the mics and we'll alternate. So, Maria, one question. The findings that we presented today, and that from this outcome of the study and from the DIAN-2 trial, what do these findings mean for families and patients, both the families who have these mutations as well as everybody who's at risk for Alzheimer's?
Well, I think the one-word answer to that is hope. Because for these families, there's no doubt that at these family meetings that we've also co-hosted with your team, Randy, with the National Institutes as well, we see that hope in their eyes when they come in and have conversations and listen to the scientific presentations. They are hand-in-hand partners with the team and want to participate and want to be a part of the solution, not only for themselves, but actually for the rest of us. And so when you think about what that means for folks with, who are thinking about sporadic, not only families who might be thinking about it, like certainly mine, but actually all of us who may be at risk for sporadic Alzheimer's, what we know is that these participants are actually our heroes, because what they are doing is offering to us the opportunity to learn from them what prevention may look like for us. Could this be our cholesterol moment? I mean, if you saw the same data that I did here, this could be our cholesterol moment of ensuring that we are going early enough to still be safe, but still be able to then follow people and reduce the prevalence, or reduce at least the onset of clinical symptoms. 5 years. We did a projection quite a number of years ago at the Alzheimer's Association that talked about what 5 years of a delay could actually mean to an individual, to their family, to society, and it is incredible. So this could very well be our cholesterol moment, thanks to these families, thanks to really, again, this global effort that has been incredibly bold. But this disease is relentless, no matter whether it's in ADAD or in SAD, and we must be as well. So that's what it means. It means hope, and it could be our cholesterol moment.
Okay. Thank you.
Or one more question.
Thank you. My name is Xiao from China. I have a question. Did you observe any therapeutic effects difference among the people with different mutations? Since we know those with different mutations will have a different disease course. Thank you.
I think that question, we addressed that question earlier, and the answer is we're looking into it. But there's a lot of information about the different mutations, but there was currently at the top level, there's no indication of any major differences in terms of progression. I do want to take the time to ask one important question here, which is to Janice Smith, someone who has done tons of drug development. How does the DIAN-2 trials, and in particular autosomal dominant Alzheimer's disease, inform drug development?
I mean, I think the data that we've seen today are really interesting, intriguing. And I think they point to some of the things that Maria was talking about as well, that it really encourages us to go early. Do those trials, identify participants who are pre-symptomatic. And in the sporadic population, that is extremely challenging, as we know. But we saw, and Tammy presented it, individuals who remained tau negative despite, being exposed to Gantenerumab for a long time, but, should have in reality progressed. So I think that these data and these studies are going to be hugely informative in terms of what biomarkers to use. We recognize clinical measures are going to be really challenging because these studies also would need to be really long. So I think we have hope, really.
Okay. Great. We want to thank everybody for joining us today, and we appreciate your attention. Thank you.